Hello, this is the first of a two-part video series on a crash course on endoscopic ultrasound guided FNA or EUS FNA of the pancreas. We will first look at some of the major reporting systems that are in use for cytopathology of pancreatic lesions, and then we will look into the basic approach to EUS FNA of the pancreas. Let's start with reporting systems. Here are two of the best-known systems internationally. First, we have the Perpendicular Society of Cytopathology System for Reporting Pancreatobiliary Cytology, and this was published in 2015. And more recently, we have the WHO reporting system for pancreatobiliary cytopathology. This is a joint effort between the International Academy of Cytology, International Agency for Research on Cancer, and the WHO. And this is part of a larger series of books on cytopathology consensus systems that currently include lung, lymph node, spleen, and thymus, as well as soft tissue lesions. So let's have a very quick look at the perpendicular system. And in a nutshell, there are 6 categories: non-diagnostic, negative for malignancy, which essentially includes non-neoplastic lesions, benign pancreatic tissue in the appropriate clinical setting, atypical, neoplastic, which includes 2 subcategories, benign, and serous cystadenoma would fall into this subcategory, and neoplastic other, which includes a spectrum of conditions such as neuroendocrine tumor, the neoplastic mucinous cysts such as intraductal papillary mucinous neoplasm or IPMN, and mucinous cystic neoplasm MCN, and also solid pseudopapillary neoplasm. Following this, we have the category for suspicious for malignancy, and then finally positive or malignant. The WHO system has some significant differences. First of all, it is a 7-category system rather than a 6-category system, starting with insufficient, inadequate, or non-diagnostic, and then benign or negative for malignancy, and this time serous cystadenoma falls into the benign category. So it does not only include non-neoplastic lesions, but also includes benign neoplasms, and then atypical. And this is where 2 new categories have been introduced: pan-low, and this means pancreatic neoplasm with low risk or low grade features, and this includes IPMN and MCN, and then pan-high, pancreatic neoplasm with high risk or high grade features. And similarly, this also includes IPMN or MCN. So the neoplastic mucinous cysts feature very heavily in these 2 new categories. And then we have suspicious for malignancy, which is similar to the perpendicular system, and finally positive for malignancy. Also, something to take note of is that neuroendocrine tumors and solid pseudopapillary neoplasms now fall into the positive for malignancy category. And the reason for this is to sync the cytopathology system with the histopathology classification system, the 5th edition of the digestive system tumors, where you can see here that solid pseudopapillary neoplasms are actually included within the category of malignant epithelial tumors. Now let's move on to look at the basic approach to EUS FNA of the pancreas. And a lot of the material that I'm showing will be from this book that I've published in 2021. And it essentially presents some algorithmic approaches to diagnosis of common conditions, including in the pancreas. Now, the first question, the most important question that we would like to answer right at the outset is, are we dealing with a solid or cystic lesion? And of course, imaging will tell us the answer. Most, if not all, of these cases will have prior imaging before the EUS-guided FNA procedure. So I've divided this into solid and cystic lesions, and we will look at solid lesions in this video, and in the second part of this 2-part video series, we will cover cystic lesions. So for solid lesions, the main differential diagnoses can be divided into non-neoplastic lesions, and these are not exhaustive lists, but these are some of the things that are more common that we may encounter, and this includes chronic pancreatitis, autoimmune or IgG4 pancreatitis, accessory spleen, which often occurs as a rounded lesion in the tail of the pancreas. Often this is mistaken for neuroendocrine tumor radiologically, and hamartoma. In terms of the neoplastic lesions, I have divided them into epithelial lesions and non-epithelial neoplasms. The commonest lesions would be the ductal adenocarcinoma with its different variants and neuroendocrine tumor. And then we also have neuroendocrine carcinoma, which is less common, and these other lesions including acinar cell carcinoma, solid pseudopapillary neoplasm, and this also can fall into the cystic category, in particular for larger tumors with cystic degeneration. And we have other entities, including metastatic carcinomas, which can occasionally go to the pancreas. For example, colonic carcinoma can metastasize to the pancreas. We also have the non-epithelial neoplasms, such as lymphoma, lipoma, solitary fibrous tumor, and schwannoma. In terms of cystic lesions, I have divided them into non-neoplastic and neoplastic lesions. So for the non-neoplastic lesions, probably the commonest cyst that we will encounter is the pseudocyst, and this is usually associated with a background or history of pancreatitis. We also have lymphoepithelial cysts, and it is worth noting that these are sometimes classified as neoplasms, foregut cysts, as well as cystic hamartomas. Among the cystic neoplasms, I have divided them very broadly into neoplastic mucinous cysts and non-mucinous neoplastic cystic lesions. Among the neoplastic mucinous cysts, the two most important entities will be the IPMN and the MCN, and of these two, the IPMN is much more common. And then we have non-mucinous neoplastic lesions, including solid pseudopapillary neoplasms, and as I mentioned earlier, this can be cystic and also solid. Neuroendocrine tumors are the same. They can also have cystic change. Adenocarcinoma can have cystic change as well as other neoplasms. So let's take a closer look at solid lesions. And of course, we will want to know whether they are benign or malignant. And to help us make this decision, we will rely on clinical and imaging findings, on cytology, of course, as well as tumor markers. And here again, there is a shortened list of some of the entities that we may expect to encounter. So I'm just going to say a few words on imaging findings in solid pancreatic lesions. And as I mentioned earlier, practically all of these cases will have prior imaging. And also, of course, being EUS-guided FNAs, they will have findings during the EUS procedure showing the EUS findings. So, for example, in pancreatic ductal adenocarcinoma on EUS, the ultrasound findings, we will see a heterogeneous hypoechoic mass, sometimes with cystic areas, and there may also be enlargement of regional lymph nodes. There may be associated dilatation of the pancreatic or common bile ducts, and this is a very important sign, particularly on the CT or MRI, where we can see an abrupt cut-off and dilatation of the main pancreatic duct, and this double duct sign, which essentially means dilatation of both the bile and pancreatic ducts. This is highly suggestive of a tumor in the head of the pancreas. In neuroendocrine tumors, one thing to take note of is that these lesions are often rounded and very well defined. And similarly, we will see the same rounded picture on CT or MRI, and in contrast, CT in particular, there will be enhancement during the arterial phase, so this is a very useful imaging finding to know. In acinar cell carcinoma, which is pretty uncommon, interestingly, they are relatively circumscribed and often very large at the time of diagnosis, and they are much more circumscribed than we would see in ductal adenocarcinoma. Circumscription is usually not a feature of pancreatic ductal adenocarcinoma. I would also like to specifically point out that in autoimmune pancreatitis, it is not very uncommon to see a mass-like appearance. The classical appearance on CT or MRI is that of a sausage-shaped pancreas. However, sometimes this process can be more localized and appear as a mass, and this may even mimic malignancy. Similarly, on the ultrasound, we can also see most often a diffusely enlarged hypoechoic pancreas, but sometimes there may be a localized mass lesion. In chronic pancreatitis, there is an abnormal appearance of the pancreatic parenchyma with hyperechoic foci, and the pancreatic duct can also appear quite abnormal. There can be areas of dilatation as well as irregularity and sometimes stones. And similarly, in CT or MR imaging, the duct is quite abnormal most of the time. It can be tortuous or have a beaded appearance, and there may also be parenchymal or even intraductal calcifications, which is quite helpful. And also, similarly to autoimmune pancreatitis, sometimes the involvement of the pancreas can be quite focal, and therefore chronic pancreatitis itself can appear as a mass lesion and can mimic malignancy. In instances of pancreatitis mimicking malignancy, CA19-9 levels may be quite helpful as a differentiating feature. However, it is worth noting that CA19-9 can sometimes be quite raised in both autoimmune as well as chronic pancreatitis, and it can be in the low hundreds. So we have looked at solid lesions and had a brief look at the differential diagnosis list as well as the common imaging findings. And I just want to show you a snapshot of two of the most common entities. There are separate videos highlighting the cytomorphological features of specific pancreatic entities on cytology. But here, this is a classical example of ductal adenocarcinoma, and we will usually see these rather disorganized sheets of glandular cells. They are sometimes referred to as drunken honeycombs because they still have a semblance to the very regimented honeycomb arrangements, but there is just something a little bit off and more disorganized in the arrangement of cells. And we also can have a degree of nuclear pleomorphism. Here is the alcohol fixed smear, and we can see this disorganized, crowded, cohesive sheets of malignant cells with a variable degree of nuclear pleomorphism. And sometimes the NC ratio can be fairly low and the cells can have quite abundant cytoplasm. We can even see a little droplet of mucin in the cytoplasm of this cell. This is an example of neuroendocrine tumor, and in contrast to ductal adenocarcinoma, the cells are usually strikingly uniform. They also do not form very crowded cohesive sheets, but rather they loosely aggregate together or they are found singly. And we can see here that there is a suggestion of rosette formation. So the cells often have a plasmacytoid shape with eccentric, rounded to oval nuclei and this classical salt and pepper or stippled chromatin. Again, there will be separate videos highlighting these individual entities. And in part 2 of this series, we will focus on cystic lesions. Before I end, I would like to invite you to check out Pathweb. This is our free online pathology resource. It is completely free to register, and the registration link is in the video description. We have a virtual pathology museum with more than 1,000 interactive specimens which you can rotate, you can magnify, and you can also view the specimen annotations. We have lots of interactive quizzes, and we also have a new section now on cytopathology approaches in Pathweb. Thank you.